Welcome back to the Deep Dive. Our mission today is to cut through all the complexity, all the noise around one of the most frustrating and, frankly, mismanaged conditions in musculoskeletal medicine: rotator cuff disorders.
It's a huge topic.
It is. I mean, if you, or really anyone you know, has dealt with that persistent shoulder pain, you get it. You understand the conflicting advice, the impulse to just jump straight to the most aggressive treatment you can find.
That is the perfect way to frame this. We are tackling a massive issue today. The sources we've analyzed, they confirm that rotator cuff or, RC disorders are just pervasive. They account for well over half of all shoulder complaints.
Over half.
Well over half of everything seen by health professionals. Globally, I mean, the burden is enormous, not just on patients, but economically. You see it in the excessive diagnostics, the prolonged recovery times. It's a real problem.
And the core of that problem, at least historically, seems to be a tendency towards, well, over-medicalization. We're talking about those initial diagnoses that often skip the essential clinical work and jump straight to, say, an MRI.
The unnecessary imaging, yeah. Which just drives up costs, it delays effective active treatment, and, ultimately it really doesn't improve the long-term outcomes.
Exactly. So our source material for this deep dive is an incredibly important piece of work. It's the new 2025 Clinical Practice Guideline, or CPG.
Right. And this guideline is just so evidence-based. It focuses specifically on how clinicians should be diagnosing, how they should apply non-surgical care, and, crucially, how to structure rehabilitation for adults with these suspected RC issues.
So the goal is simple, but it also feels kind of radical.
It is. Better, faster patient outcomes. And the way to get there is through rigorous adherence to the best available data, not just old habits.
Okay, before we really unpack the CPG's recommendations, let's just quickly set the table. When we say rotator cuff, we're talking about 4 key tendons that stabilize the shoulder. Who are the 4 players here?
Right, so these 4 muscles, they all start on the scapular shoulder blade, and their tendons come together, they form a cuff, really, that inserts on the head of the humerus.
Providing that stability.
Crucial stability and movement control. And they are the supraspinatus, the intraspinatus, the subscapularis, and the teres minor.
And when this guideline, the CPG, refers to rotator cuff disorders, is it talking about every single ache and pain in the shoulder?
No, it's very specific. We are focused on the most common things a clinician sees, so RC tendinopathies, and that includes cases with or without calcifications, and also partial thickness RC tears.
Okay, so what's excluded?
This is a key point. This guideline excludes full thickness tears. Those often follow a completely different, often surgical pathway, so we're not talking about those today.
Got it. And I noticed the CPG is very clear that this guidance applies to a whole cluster of related and sometimes kind of confusingly named diagnoses, things like subacromial pain syndrome, subacromial impingement.
Yes, and you can add subacromial bursopathy to that list, even long head of biceps tendinopathy. The CPG basically bundles all of these under the umbrella of RC tendinopathy.
Why do that?
Well, it's pragmatic. In clinical practice, all these conditions, they frequently present with the same core symptoms, a painful arc of motion, weakness, functional problems.
And they respond to the same treatments.
Exactly. They often respond to the same non-surgical management strategies, so it's a practical way to approach the diagnosis without getting bogged down in semantics.
Okay, understood. And finally, just so our listener can really grasp the weight of these findings, can you quickly remind us how the CPG assigns its authority? How do we know how strong a recommendation is?
Absolutely. This grading is critical. When we say a recommendation is grade A, that means it's based on strong evidence. The clinical action is, for all intents and purposes, a must.
Okay.
Grade B is moderate evidence, which means a clinician should take that action. Grades C and D, they range from weak to conflicting evidence, so the action may be appropriate, but it's not a strong recommendation.
And the last one? Grade F.
Grade F is based purely on expert opinion or consensus. It's there to guide best practice when, high-level data just isn't available yet. And sometimes that means challenging some pretty deeply ingrained habits. We'll be using those grades throughout this deep dive to really signal the level of certainty.
Perfect. Okay, let's jump straight into the assessment phase, because this is where the CPG delivers its first, and maybe its biggest, message. The foundation of diagnosis is clinical skill, not a machine.
That's the entire thrust of this section, the very first recommendation. And it's interesting because it's a grade F-SO expert opinion. It states that clinicians must include a detailed subjective assessment and history of the injury right at the beginning.
You can't treat a shoulder without understanding the person attached to it.
That's it, exactly.
That sounds, I mean, that sounds obvious. But what specific things are clinicians often missing that this guideline really emphasizes? What makes a subjective assessment truly comprehensive here?
It goes so far beyond just when did it start and where does it hurt. The CPG mandates collecting the usual stuff age, gender, hand dominance, but then it dives really deep into the context.
Okay, like what?
We're looking at specific work requirements, sports, leisure activities, medications, any comorbidities, the precise mechanism of injury, and this is crucial, the patient's explicit functional limitations and their personal goals.
So, for example, if a patient is an electrician who needs to work overhead, the assessment needs to capture that specific requirement, not just a note that says pain when lifting arm.
Precisely. And even more critically, the subjective assessment must screen for psychosocial and contextual factors early on. This is where we start sniffing out those yellow flags, which we'll get into more detail on later, but they are intrinsically linked to the history.
Right.
Is the person highly stressed? Do they have poor social support? Are they terrified to even move their arm? I mean, these are data points that influence prognosis just as much as the tendon's structural integrity.
So, moving from the subjective to the physical exam, what are the absolute non-negotiables?
Okay, so the must-haves are observational and objective. Clinicians must observe for signs like deformity, atrophy, muscle wasting, and any swelling. They must measure active and passive range of motion and muscle strength.
And you mentioned something else, the neck.
Yes. And significantly, they must perform a preliminary screening of the cervical spine.
Why is that mandatory cervical spine screen so important?
Because the shoulder is so often just the scapegoat. Pain referring from the neck, say a nerve root irritation or a cervical facet joint issue, it can perfectly mimic that deep, dull ache we associate with shoulder problems. A quick screen can rule out these major differential diagnoses and make sure you're treating the true pain generator.
So if you don't screen the neck,
you risk spending months treating a shoulder that was never the primary problem to begin with.
And this brings us to a critical safety checkpoint, something I think all our learners should really internalize, the identification of red flags.
Absolutely. Clinicians must identify red flags. These are the definitive signs of serious pathology or systemic disease that require immediate medical referral. They often bypass conservative care entirely.
So what are we talking about here?
We're talking about a suspicious deformity after a trauma, unexplained systemic symptoms like a fever or chills, night pain that's totally unrelated to movement, or any suspicion of malignancy. It's just basic clinical safety, and failing to screen for these is, well, it's unacceptable.
Let's talk about objective measurement, because this is where the CPG really pushes hard against some pretty outdated practices. There's a grade A, strong evidence recommendation here, and it's essentially telling clinicians to throw away the guesswork.
This is a major behavioral shift that's needed in clinics. The guideline says clinicians should use an objective tool, an inclinometer, a goniometer, or even a validated smartphone app to measure active and passive range of motion.
Instead of visual estimation.
Exactly, instead of just eyeballing it. Visual estimation is notoriously unreliable. It makes it impossible to track subtle progress or even regression across treatment sessions. You need the numbers.
And the same rigor applies to strength testing. We're moving away from the classic manual muscle testing, or MMT scale, right?
That's another grade A recommendation. And it's huge. Clinicians should use a handheld dynamometer to objectively measure isometric muscle strength. This is one of the most powerful data points in the whole CCG, and it really undercuts decades of clinical tradition.
So explain why manual muscle testing is so limited, especially when you're trying to track someone's recovery.
The problem is really the ceiling effect and its lack of sensitivity. Traditional MMT uses a 0 to 5 scale. The evidence shows that to score a 4 out of 5, which, most clinicians would consider good strength,
right,
you only need to generate about 20% of maximal muscle strength.
Only 20%.
Only 20%. So think about it. If your patient starts treatment at 20% strength and they progress to 50% strength, they might score 4 out of 5 on both tests. It looks like no progress, even though their strength has more than doubled.
Whereas a dynamometer gives you a hard number.
Exactly. It gives you a quantitative reading in pounds or kilograms. It provides granular, objective data for monitoring their rehab success and justifying your progressions.
That 20% threshold is an enormous insight. It basically means if you're only using MMT, you're effectively flying blind on actual strength gains.
Precisely. You need that objective metric to justify progressing the load in their exercise program, which, as we'll see, is the core treatment.
Now, you mentioned a specific type of measurement that the CPG explicitly discourages, even though it's been pretty popular in some circles, dynamic scapular ROM measurement.
Right. The caution there is very clear. The recommendation is that clinicians should not use measures of dynamic scapular ROM, even with sophisticated tools. The key issue is reliability and validity. When you try to track the movement of the scapula relative to the rib cage during arm elevation, the measurement error is it's too high.
So the data is noisy.
It's very noisy. Clinically, trying to draw conclusions from dynamic scapular kinematics is often misleading, and it just adds unnecessary complexity without improving your diagnostic or prognostic accuracy. It's a great example of the CPG telling clinicians to focus on measures that actually matter.
Okay, so we have the history, objective ROM, objective strength. The next piece of the puzzle is the special orthopedic test. The painful arc, the empty can, the Hawkins-Kennedy. How much weight should we give to a single positive test result?
Very little. The consensus is that clinicians should not rely solely on clinical tests to diagnose rotator cuff tendinopathy. The diagnostic value of any single test is honestly modest, and that's a point reinforced by grade B or moderate evidence.
So a physical exam is more of a pattern recognition exercise.
Exactly. It's not a checklist where one positive test equals one diagnosis.
But if we have to pick the most useful tests, which ones rose to the top in the meta-analyses?
Well, we can categorize them based on likelihood ratios, or LRs. LRs basically help us determine how much more likely a condition is given a positive or a negative test result.
Okay, that makes sense.
So to confirm the diagnosis, meaning to increase your suspicion when the person already has shoulder pain, the painful arc test had the highest positive likelihood ratio, an LR plus of 3.44.
Which means a positive test makes the diagnosis over 3 times more likely.
Exactly. Conversely, to rule out the diagnosis, to help you decide it's probably not an RC issue, the Hawkins-Kennedy test showed the lowest negative likelihood ratio, an LR of 0.25. A low negative LR is excellent for ruling something out.
So that gives clinicians a really valuable framework. Use the painful arc to confirm your suspicion, and use the Hawkins-Kennedy as a screen. If it's negative, maybe look elsewhere.
And accuracy only gets better when you combine them. The sources noted that using a cluster specifically, if you get 3 out of 5 common tests positive, that significantly improves your predictive values. The LR plus climbs to 2.93, and the LR drops down to 0.34. Clinical reasoning requires clustering, not just relying on single tests.
This whole exhaustive clinical assessment process finally brings us to the most controversial point: initial imaging. This is the recommendation that really pushes back against patient expectation, clinical tradition, maybe even insurance companies.
This is a landmark moment in the CPG. The grade F consensus is crystal clear. Clinicians should not prescribe initial diagnostic imaging, that's MRI, X-ray, CT, to confirm RC tendinopathy in the initial management pathway.
That is a massive statement.
Yeah.
Why such a hard line against imaging right away?
There are 3 critical reasons. First, the clinical exam is highly reliable when it's done correctly. Second, cost. MRIs are expensive, and we are trying to manage the economic burden of this condition.
Okay, and the third?
The third, and this is maybe the most important one, is incidental findings.
Ah, the incidental-lomas.
Exactly. Many people over the age of 40 have asymptomatic, partial, or even full-thickness tears on their MRI that cause them 0 pain. If a clinician orders an MRI immediately, they risk finding one of these.
And that causes huge patient anxiety.
Tremendous anxiety. It drives fear avoidance behavior, and it can lead to unnecessary passive treatments or even surgery when the actual source of the pain might be something non-structural that's easily managed with exercise.
So the immediate image itself can become a yellow flag, right? It increases fear and potentially delays the active recovery that the patient actually needs.
Precisely. It creates a structural label for what might just be a load intolerance or a pain sensitivity issue, and that can fundamentally derail the entire active recovery narrative.
So when is imaging justified then?
Imaging may be recommended, but only if symptoms fail to resolve or show significant improvement within a maximum of 12 weeks of appropriate active non-surgical management.
12 weeks.
Or, of course, if there's suspicion of a severe lesion, like a full-thickness tear following some acute trauma.
And if that 12-week benchmark is hit and you need to order an image, is one type preferred over another?
Yes. There's a hierarchy, also based on grade F consensus. Clinicians must prioritize diagnostic ultrasound.
Why ultrasound first?
It's preferred because of its significantly lower cost, the lack of radiation, and its diagnostic properties are really comparable to a standard MRI for confirming most RC disorders, especially tendinosis.
But the sources also pointed to the superiority of MRI with contrast for specific types of tears. How do we balance that?
That's a key nuance. MRA, or magnetic resonance arthrography, it does show superior diagnostic value for partial thickness tears. The sensitivity is about 0.81 compared to 0.67 for a standard MRI.
And why is it better?
The contrast agent that's injected into the joint capsule, it just delineates the boundaries of the tear much more clearly. However, the CPG maintains that you start with ultrasound because MRA is far more invasive, it's costly, and it's resource intensive. You only escalate to MRA if you've failed conservative care and you need surgical level detail on the tear's geometry, usually because surgery is now actively on the table.
So the cost-benefit analysis favors starting simple.
Always.
This whole assessment strategy seems designed to identify not just the pathology, but the potential for it to become chronic. So let's finish part one by talking more about those prognostic factors, the yellow flags. This gets a grade B recommendation, so moderately supported by evidence that clinicians should be actively screening for them.
This is where we connect the patient's psychosocial world to their physical pain. Identifying these personal, clinical, psychosocial, or work-related factors that might influence prognosis it's mandatory. If you miss the yellow flags, you might miss the primary driver of their persistent disability.
We heard a few key risk factors linked to poor outcomes. Let's focus on that age metric first.
Advanced age is a huge risk factor. Being 50 years or older is strongly associated with difficulty returning to work, and being 55 or older, that significantly increases the risk of chronicity. It carries an odds ratio of 3.8.
And just for our listener, an odds ratio of 3.8 means that people in that age category are 3.8 times more likely to experience chronicity compared to younger adults, even with the same initial injury severity.
Right, it's a significant multiplier. Other factors include a prolonged duration of symptoms. The longer you've had the pain, the harder it is to get rid of, and high pain intensity. But the psychological factors are just as potent. Psychological distress, catastrophizing, and kinesiophobia.
Can you just quickly distinguish between catastrophizing and kinesiophobia for us? They often get lumped together.
They're related, but they are distinct. Catastrophizing is an exaggerated negative orientation toward the pain. It's believing the worst possible outcome is going to happen, thinking the pain is uncontrollable, feeling helpless.
And kinesiophobia.
Kinesiophobia, or fear of movement, is the resulting behavior. It's avoiding activity because the movement itself is perceived as dangerous and damaging. If you catastrophize, you are very likely to become kinesiophobic. Clinicians who identify these factors need to address them immediately to mitigate that high risk of chronicity.
And finally, the work environment. That also plays a big role.
A huge role. Work-related high demands carry an odds ratio of 4.1 for persistent pain. This could be physically demanding jobs, high stress, or just job dissatisfaction.
And what about protective factors?
The protective factors, interestingly, they reinforce the CPG's overall message. Undergoing rehabilitation or medical care was highly protective against chronicity, with an odds ratio of 5.4. And perhaps counterintuitively, not regularly taking pain medication was also protective at an OR of 5.3.
So that really underscores the idea that active coping and engagement in recovery are far better than just passive avoidance strategies. Okay, let's shift gears and discuss the solution. Rehabilitation. Part 2 kicks off with foundational care, patient education, and self-management, which has a grade C recommendation.
Education is the essential starting point, especially for tackling those yellow flags we just discussed. Clinicians should provide patient-centered, individualized education. It has to cover the condition, the pain management options, and self-management strategies.
And it has to be tailored.
It has to be. You have to consider the patient's beliefs, their health literacy, their goals. You can't just lecture someone who is kinesiophobic. You have to meet them where they are.
What are the key educational themes that clinicians should be focusing on?
First, pain biology. Helping the patient understand that pain is an output of the nervous system. It's a warning signal, and not necessarily a one-to-one reflection of structural damage.
Okay.
Second, giving them guidance on exercise intensity and an appropriate pain response. They need to learn how to safely work into their pain tolerance, how to load the tissue without alarming the nervous system.
And finally,
activity modification and pacing. So not stopping all activities, but modifying the most painful ones while maintaining their overall function.
This all sets the stage for the true cornerstone of recovery, the Grade A, strong evidence recommendation, active exercise programs.
This is the gold standard. Clinicians should prescribe an active rehabilitation exercise program as the initial treatment modality for everyone with RC tendinopathy. The evidence is just conclusive. Moderate to high certainty evidence shows exercise reduces symptoms and improves disability across the short, medium, and long term.
It provides that necessary mechanical stimulus.
For tissue adaptation and load tolerance, yes.
Let's dive into the nuances of the exercise prescription itself. Does the type of exercise matter profoundly? Is a highly specific motor control program, for instance, better than just general gym work?
The CPG did look at specificity, and the findings offer some insight. Motor control exercise programs may be slightly better than standard generic exercise programs for reducing pain and disability in the medium and long term.
So there's a slight edge.
A slight sustained advantage. It suggests that while general strengthening is good, focusing on precise movement patterns and stability, sort of re-educating the shoulder, offers a marginal benefit. The same applies to scapula-focused programs, which may also reduce pain and disability in the medium term.
And what about load? We often hear about heavy, slow resistance training being so beneficial for tendinopathies. Was high-load exercise confirmed as superior here?
Interestingly, no. The analysis showed that high-load exercise programs demonstrated no significant difference in outcome when compared to low-load exercise programs.
That's surprising.
It is. It seems the overall benefits of strength training and just general tissue loading are the primary drivers, regardless of whether the load is high or low. And that's good news, really. It allows clinicians to safely start patients who have low irritability on higher loads, but still have an effective pathway for patients who are highly sensitive and need more gentle loading.
Now we get to the finding that has massive implications for the healthcare system, especially in systems where rehab is delivered in person. The difference between supervised and unsupervised exercise.
This is a major challenge to the traditional physical therapy model. The CPG concluded, based on low certainty evidence but very consistent findings, that clinic-based supervised exercise programs are not significantly more effective than home-based, unsupervised exercise programs for pain and disability reduction.
That's controversial. If I'm an insurance payer, I read that and I think, why am I paying for 12 sessions of in-person supervised care if the patient can achieve the same outcome at home?
Precisely. The implication is profound. It fundamentally shifts the role of the clinician. The true value isn't in watching the patient lift a dumbbell. It's in the initial assessment, the diagnosis, the education, the programming, and ensuring adherence.
So if adherence is high,
the physical presence of the therapist during every single rep may be superfluous to the physical outcome. It reinforces that protective factor we mentioned earlier. The act of undergoing rehabilitation is the key, regardless of the setting.
that makes the early education phase, the how and the why of the exercise, even more critical. The clinician is essentially training the patient to be their own movement expert.
That's exactly the goal. Self-efficacy. If the patient believes they have the tools and the knowledge to manage their condition outside the clinic, their dependence decreases and their adherence, which is the most crucial factor of all, goes up.
Now, while exercise is the gold standard, manual therapy is still a highly utilized intervention. What's its role according to the CPG?
Manual therapy, which includes things like joint mobilizations, spinal manipulations, soft tissue techniques, it gets a grade B recommendation. Clinicians may use it, ideally combined with exercise, but its primary evidence-based benefit is strictly limited to short-term pain reduction.
Why the heavy emphasis on short-term?
Because when manual therapy is added to an exercise program, it significantly reduces pain with small to large effect sizes compared to exercise alone. But critically, it does not significantly reduce long-term disability.
So it's a temporary fix.
It's excellent at down-regulating the nervous system, modulating pain, and restoring some temporary range of motion, which makes it easier for the patient to then perform the necessary exercise.
So it's an enabler for the main event, but it is not the main event itself.
Precisely. If you stop the manual therapy but you don't do the exercise, the pain comes back because the tissue adaptation hasn't happened. And the CPG offered another specific point on this. Thoracic manipulation showed no difference compared to sham manipulation for immediate pain or disability reduction.
So the evidence base really requires manual therapy to be viewed as a temporary pain relief tool.
An adjunct, yes.
Okay, finally in the rehab section, we have taping, both rigid and the elastic kinesiology taping. We see it all the time in sports.
Taping gets a grade D recommendation, which means conflicting evidence. Clinicians may use taping as an adjunct to active rehab for short-term pain relief, but the evidence is simply too weak and inconsistent to give it a strong recommendation.
So it's a maybe.
It's a maybe. Some studies, for example, showed kinesio taping reduced pain with movement compared to sham taping, but then it failed to reduce overall pain or disability. It's a very low certainty intervention, likely used more for temporary sensory feedback than any true biomechanical correction.
Let's transition now to the pharmacological and injection landscape. This is critical for medical providers and for patients who are seeking rapid pain relief, but it's also an area that's just fraught with risks and conflicting outcomes.
We'll start with the basics. For acetaminophen or Tylenol, we have a grade C recommendation. Clinicians may recommend it for mild to moderate pain in the short term. The evidence specific to RC tendinopathy is a bit limited, but expert consensus supports its use as a standard first-line, over-the-counter analgesic.
Because it has a favorable side effect profile.
Especially compared to NSAIDs, yes.
Speaking of which, let's talk about non-steroidal anti-inflammatory drugs, or NSAIDs, both oral and topical.
Oral NSAIDs get a grade B recommendation. Clinicians may recommend them to reduce pain in the short term. They're significantly better than a placebo for pain reduction.
But there's a however.
There is a big however. The CPG places a huge emphasis on discussing the potential harms. We have to consider the cardiovascular and gastrointestinal risks, especially with prolonged use, and there's that potential negative impact on tendon healing that we've seen in some animal models.
That risk-benefit analysis is crucial. A patient might not realize that the pain relief they're getting comes with those systemic risks.
Absolutely. The prescribing clinician has a duty to weigh that cost. And regarding topical NSAIDs, they might offer similar reductions in disability with fewer systemic adverse events, but that data isn't specific to a deep tendinopathy like the rotator cuff, where penetration might be less effective.
Next, we have to address opioids. Given the severity of the opioid crisis, I assume the CPG takes the strongest possible stance against their routine use.
It does. The grade C recommendation is explicit. Opioids should not be recommended as a first-line pharmacological treatment. They're designated as a last resort.
A grade F consensus.
Right. Reserved for adults with severe pain and disability who are refractory or have contraindications to all other analgesics.
And what's the rationale against them, beyond the obvious addiction risk?
Well, for nonspecific chronic musculoskeletal pain, which is how RC tends to present, opioids are often no more effective than NSAIDs for pain reduction. But they introduce this significant risk profile. Adverse events like vomiting, dizziness, dependency, overdose death, they're all substantially higher.
So for a condition like RC tendinopathy, the risk-benefit calculation is just way off.
Overwhelmingly, it disfavors opioids. The prescribing clinician must commit to regularly reassessing the risks of dependency.
Okay, let's move to corticosteroid injections, or CSI. These are probably the most common medical intervention for RC pain after NSAIDs.
CSI is a very popular tool, but the CPG issues a clear warning here. They should not be used as a first-line treatment. That's a grade C.
Okay, but they may be recommended for short-term relief.
Yes, they may be recommended for short-term pain and disability reduction, but for a very specific and maximum period of up to 8 weeks. That's a grade B recommendation.
Why that hard limit of 8 weeks?
Because the evidence shows that while CSI is excellent at temporarily calming down inflammation and pain, exercise significantly outperforms it in the medium term. CSI doesn't address the underlying load capacity of the tendon.
And there's a risk of weakening the tendon.
There is a theoretical risk with repeated injections of weakening the tendon over time. So it reinforces the need to use them sparingly and to transition the patient immediately into an active loading program. It's a window of pain relief intended solely to facilitate the grade A treatment, which is exercise.
And if a patient needs that 8-week window, is there a superior technique for the injection itself?
Yes. Grade B evidence confirms that if resources permit, clinicians should use ultrasound guidance for subacromial CSI.
And that's more effective.
Ultrasound guidance shows greater pain reduction in the short term compared to just landmark-guided injections. The increased accuracy of the drug placement likely contributes to better short-term outcomes, and it also reduces the risk of injecting directly into the tendon sheath itself.
Now we get into the more specialized injections, often reserved for cases that have failed basic rehab. Let's start with calcific lavage or needling. which targets that subset of patients with calcific tendinopathy.
This is a really robust recommendation. For adults with calcific RC tendinopathy who are refractory to initial treatment, clinicians should use or recommend calcific lav needling. It gets a grade B.
So the evidence is strong.
It is. The evidence shows that calcific lavage is superior to treatments like shockwave therapy in the long term, both for reducing pain and, crucially, for physically reducing the size of the calcification deposit. It's a very effective, targeted treatment for that specific pathology.
Let's discuss the highly debated platelet-rich plasma, or PRP, injections. Given all the hype and the cost, what did the CPG conclude?
PRP is. It's difficult. It's categorized as grade D conflicting evidence, and it's strictly excluded as a first-line treatment. That's grade F. So clinicians may use it, but they have to be very transparent about the conflicting data.
Why is the evidence so conflicting on PRP?
The main issue is a lack of standardization. PRP is derived from the patient's own blood. But the preparation method, how the blood is spun, the concentration of platelets, whether it's leukocyte-rich or poor, it varies wildly between studies and clinics.
So it's hard to compare apples to apples.
Exactly. This variability makes synthesizing the data extremely difficult. Some low-quality studies suggest PRP may reduce pain compared to a corticosteroid injection in the long term, but the general consensus is that it is not superior to simple exercise or corticosteroids in the medium term. The cost and the uncertain efficacy demand caution.
What about hyaluronic acid, or HA injections?
HA injections, they follow a very similar pattern. Conflicting evidence grade D and not a first-line treatment. Grade FHA may be used in the short and medium terms.
What's the theory behind it?
It's often used to improve the lubrication and viscosity within the joint or the subacromial space. Some studies suggest it may reduce pain compared to PRP or CSI in the short to medium term, but when you compare it head-to-head against a simple placebo, the evidence is pretty weak.
So again, caution is necessary.
Due to the cost and the lack of robust, standardized data, yes.
And just a quick wrap-up on prolotherapy, suprascapular nerve block, stem cells, and botulinum toxin.
For prolotherapy, the evidence is conflicting. It doesn't seem to significantly reduce pain in the short or medium term compared to placebo, though some data suggests some long-term benefits. For the others, suprascapular nerve block, stem cells, and Botox, there is currently insufficient or just very limited high-quality evidence to support any recommendation at all for RC tendinopathy.
Part 4 is where we really consolidate everything, emphasizing that clinical decision-making is highly contingent on the specific type of pathology, calcific versus non-calcific. This distinction seems to be a game changer for physical modalities.
That is the crucial clinical takeaway for this entire section. If calcification is present, the treatment algorithm changes radically for these electrical or mechanical therapies.
Okay, let's start with extracorporeal shockwave therapy, or ESWT.
Okay, for rotator cuff tendinopathy without calcification, clinicians should not use ESWT, grade C. It provides no measurable benefit.
But if there is calcification?
If there is, then clinicians may use ESWT, also grade C, and there's a clear distinction in the dosage. High-energy ESWT is superior to low-energy ESWT for reducing pain and disability in chronic calcific cases.
So the mechanical force is important.
It appears that the forces from high-energy shockwave are necessary to help fragment and resorb that calcium deposit.
Okay, next up is therapeutic ultrasound, or TUS, which has been a standby intervention in physical therapy clinics for decades. Is it recommended?
TUS is generally discouraged, regardless of the pathology. Clinicians should not use TUS for RC without calcification, that's grade B. And perhaps more surprisingly, clinicians should not use TUS for RC with calcification either, a grade C.
Wow, so it's out across the board.
Pretty much. The evidence suggests TUS just lacks the necessary penetration depth or the biological effect to be clinically meaningful for a deep tendon pathology like the rotator cuff, regardless of its calcific status.
So TUS is out, ESWT is only in for calcification. What about laser therapy?
Laser therapy, very similar to shockwave, is conditionally supported only in the calcific context. For RC with calcification, clinicians may use laser therapy either alone or as an adjunct. That's a grade C.
Yeah, and acupuncture.
Acupuncture may be used as an adjunct, also grade C, but alongside an active rehabilitation program. Similar to manual therapy, it appears to serve primarily as a short-term pain modulator to enable the patient to adhere to the core treatment, which is exercise.
Moving beyond the clinic, let's look at the external environment. Ergonomic interventions get a grade C recommendation.
Right. Clinicians may recommend or perform ergonomic adaptations to reduce occupational shoulder pain, which links directly back to those high-demand work risks we talked about earlier. The evidence is low certainty, but some specific findings are useful.
Like what?
For instance, the use of an arm support combined with an alternative mouse showed a significant reduction in long-term pain and discomfort for office workers.
That suggests a multimodal ergonomic intervention is necessary, rather than just relying on a single change.
Exactly. Behavioral changes matter too. The use of supplementary breaks significantly reduces shoulder and upper arm discomfort in the short term. But simple interventions like a sit-stand workstation or just an alternative mouse used alone showed no significant benefit for neck or shoulder pain.
So it underscores the need for specific, targeted support for the arm, not just changing the trunk position.
Correct.
Finally, we need to address the guidance for the athletic population. Return to sport. RC tendinopathy is endemic in overhead sports, baseball, water polo, and this whole section is grade F, so it's consensus-based.
Right. It's because of the difficulty of conducting high-quality intervention studies in elite athletes. So since the data for definitive protocols is missing, the CPG provides a really crucial framework for assessment.
And what does that framework look like?
Clinicians may consider the athlete's capacity and their load tolerance for the RC muscles and tendons, as well as the entire associated shoulder complex, when they're developing a progressive return-to-sport program.
When assessing readiness to return, what objective measures are required?
Well, clinicians may use reliable, valid, and responsive patient-rated outcome tools, things like the Western Ontario Rotator Cuff Index or the Penn Shoulder Score, or even just the standard numeric pain rating scale to gauge pain and readiness.
And in terms of physical performance, what's considered necessary?
Functional performance measures are mandatory, something like the closed kinetic chain upper extremity stability test or CKCUS. But the highest consensus point is the holistic view. The assessment must include the entire kinetic chain.
The trunk, the pelvis?
The trunk, the pelvis, the lower extremities. They are the primary force generators for upper extremity sports. A weak core or poor hip rotation means the shoulder has to compensate, and that leads to overload.
So the CPG emphasizes that while we lack timelines, the roadmap for assessment focuses on quantifying the shoulder's strength and functional capacity, while also making sure the rest of the body isn't setting the shoulder up for failure.
That's the key knowledge gap the CPG highlights. We don't have definitive timelines or factors that guarantee a successful return to sport just yet. The framework is currently a detailed consensus roadmap for a thorough, comprehensive assessment.
This deep dive into the 2025 rotator cuff CPG has provided an incredibly clear, evidence-based roadmap, and it's challenged a lot of traditional clinical assumptions. Let's summarize the 4 most critical takeaways, the learner's cheat sheet that you should carry forward.
Okay, number 1, ditch the initial MRI. Diagnosis must rely on a comprehensive clinical exam, a detailed history, objective ROM, and strength quantification using dynamometers, and aggressive psychosocial screening for yellow flags. Imaging is strictly reserved for cases that fail to improve after 12 weeks of active care.
And when you do image, ultrasound first.
Ultrasound is the prioritized, cost-effective initial choice. Okay, number 2, exercise is the non-negotiable core. It's grade A. Active rehab is the cornerstone of successful recovery. And remember, supervision provides limited added benefit. The focus should be on expert programming, patient education, and maximizing adherence to home-based, unsupervised exercise.
Number 3.
Injections are for short-term pain modulation, not a cure. Corticosteroid injections provide temporary relief for up to 8 weeks, but exercise is superior in the medium term. And newer injections like PRP and HA, they remain grade D, conflicting evidence, and should never be a first-line treatment.
And the final one, number 4.
Calcification changes the game. For non-calcific tendinopathy, things like therapeutic ultrasound and shockwave are generally discouraged. But for calcific cases, specialized targeted interventions like high-energy shockwave and calcific lavage are specifically supported and recommended.
That is a powerful synthesis of the data. But as we established in Part 1, the CPG strongly mandates screening for psychological factors like kinesiophobia and catastrophizing our yellow flags. Because they're associated with a poor prognosis and a higher risk of chronicity, they carry those high odds ratios.
Absolutely. The clinical requirement to address those is clear.
Yet, buried within the research that informed the CPG is a difficult finding. And that is, while those psychological factors are highly associated with initial pain intensity, some of the better longitudinal studies show they are only weakly associated with actual physical disability outcomes later on.
That presents a fundamental tension in musculoskeletal care right now.
It does. If the best available evidence supports active exercise as the grade A treatment for the physical tissue, how should clinicians balance that physiological reality with the subjective, personalized, and often highly resistant pain experience that's driven by these non-structural psychological factors? Especially when the long-term data suggests the link to those factors is weaker than we might assume.
It's a huge question.
I mean, do we prioritize the mind or the muscle when the evidence for each points in different directions over time?
That demands a deeper, more integrated approach to pain science. We need longitudinal research that doesn't just measure the presence of yellow flags, but that quantifies the effectiveness of psychologically informed physical therapy interventions, the kind that explicitly addresses fear and catastrophizing, and compares that to exercise alone.
So until we bridge that research gap.
Until we bridge that gap, managing RC tendinopathy is going to remain an artful balance of loading the tissue while at the same time calming the nervous system.
A fascinating area that clearly demands further exploration. Thank you for this deep dive into rotator cuff tendinopathy.
It was my pleasure.